because they recognize there is a problem with space, acuity at the adult ERs, that they will offer their patients IM medicine in the waiting room. That was part of this program, but they couldn't give the nurses to give it.
Right, right.
Because the nurses didn't feel comfortable having unmonitored patients in the waiting room getting narcotics.
That makes sense.
Yeah. But in reality, and I hear the same thing from our nurses, well, this kid's had too much narcotics. And occasionally maybe that's true. But in my 25 years, I've never seen anybody overdose in the emergency room that had sickle cell. Never seen it.
Yeah.
So, you know, I just don't think we should be in the business of trying to judge how much pain you. If you come in to my hospital and you broke your arm, it's not up to me to decide how much pain you're in or how much pain you're in. And I think that's the idea that we, as providers, have to understand.
Yeah, I think that's one of the biggest obstacles, actually.
Oh, sure.
Oh,
and
they're
that's
not in pain, they're eating Cheetos. Yeah. Or, you know, they're not in pain, they're running around.
We just applied for a new grant that has to do with all the adult EDs in the area, where that we would somehow work with them to look at satisfaction, how their patients were treated, and how they could do better, and how we can follow up with their patients. And we should know any month now whether we got that grant to do that. Any other questions?
Well, I'd just like to make a comment. I would feel as a nurse, as an ER nurse, uncomfortable giving, narcotics in a waiting area. I think there's a difference between chronic illness versus like someone who's just broken a bone. And I think for our sickle cell patients, it's so critical to get a thorough medical history to make sure that we understand what you've been taking at home before giving them something, in a waiting area. So I would have problems giving narcotics in a waiting area.
Well, and that's basically what happened, but hopefully the protocol states the triage nurse would have a certain amount of responsibility to get that information before. It's just like the intranasal fentanyl. The way, if it worked right in our emergency room, basically people should get their intranasal fentanyl at triage. There's really no difference. You don't need to be on a monitor to get intranasal fentanyl. We do not routinely put people on monitor just because they get intranasal fentanyl. So there really is no difference. It's more of a change, and there's no, not to put this on the nurses. Doctors are the greatest problem, because doctors decide, who gets medicine and how much and how often, and they are the greatest problems. If you look at the global effect of why patients are not getting adequate doses of medicine and adequate frequency of medicine, it's doctors. So, but it's it's a mindset. We're so used to dealing with acute pain. We do a very good job, whether adult or pediatric, of dealing with acute pain. Somebody that came in broke a bone. We make sure they're not in pain. We don't do a good job necessarily with chronic pain with most diseases. And then you tag on that the cultural differences, the racial differences. It's a problem, and it's a multifactorial problem. I'm not going to tell you that that there's one answer that's going to fix it, because it's not. It's probably a generational thing too. I think as we get more younger doctors, we'll have less people who say, we've always done it this way. So that's a big thing in medicine. We've always done it this way. I hear that every day.
Do you think that there's a way to teach, to educate the new generation of doctors to be able to deal with chronic pain in a better way?
Yeah, I think that residency programs are attempting to do that now. Certainly we try to teach our residents that they need to look at things a different way. And, but, you have people who have been out in residencies 20, 30, 40 years in EDs who are making these decisions. So you know, maybe in 20 years, things will be totally different, but I just don't see them changing that quickly.
I do just want to clarify something about which I know you all know, but for sickle disease, when we assess pain, they do have a chronic pain syndrome, which is different than their VOC or VOE event, which is acute. This is an acute, very different from their chronic pain, extremely different in the way it presents and how it needs to be treated. And so when we have patients in the ED, it is considered an acute event, which is, and I've always felt, I mean, you guys are amazing in front trenches, you're very compassionate. And when you've had these difficult patients that are slamming their hand against the wall because they're occasional teenage boys, maybe that are angry because they're in pain, I've always wished you could come meet them in the clinic when they're well, because they are the most polite children I have ever met in my life. And when you see them in pain, you know they've got to really hurt because they are really nasty.
Well, I have no problem with the teenage girls.
Okay.
They're the ones that can be really nasty.
They're monsters.
That's right.
And so I know the compassion you have at frontline, but I always try to remember, like, God, when I saw them last month, they were totally.
But see, we don't have that benefit.
Right.
I think that's a great benefit.
Right, it would be nice for you to come to clinic and see.
Well, you know, I do sickle cell camps, so I know some of these people their whole lives.
Right.
You know, so I have, so a lot of them, I have a different report. I've been doing camp for 15 years. So, you know, I've seen some of them children that they're bringing now. So, you know, but, you know, it's difficult. It's difficult being a teenager, period. And then having a chronic disease over on top of that. And then, you know, feeling people chronically don't listen to you, you know. I mean, people don't understand. You know, our protocol says you get 3 doses of medicine. Then you have to either be admitted or go home. That's our protocol. You know, people want to change it. You know, they don't like it. I understand that. But that's the protocol. You can't get here and have unlimited doses of medicine, IV medicines, and ED. It just doesn't work.
Before you go away, can you talk to us about the medicines that they're on? Like I don't understand. Like what does hydroxyurea do? What does vitamin B do? I get the penicillin business. Why are these other meds that they're on every day? What do those do for them? Why are they on those meds?
Well, hydroxyurea has been one of the few major advances in sickle cell, and it has been shown to decrease. You know, and I'm not an expert in this, but it's shown to decrease the frequency of crises in patients. But there's certain criteria for, you know, patients to be on it. Everybody's not on hydroxyurea.
So hydroxyurea gets the bone marrow to kick out more fetal hemoglobin. So there's a few patients with sickle cell disease that carry that fetal hemoglobin from when they were born. It's called fetal hemoglobin. For some reason, they carry it for their lifetime. And those kids hardly ever have crisis. We call it persistent fetal hemoglobin syndrome. So hydroxyurea was a cancer drug, and in these doses, it does make the bone marrow kick out kind of fetal immature hemoglobin. And that, I don't know exactly why chemically or biochemically. You can ask Keith or Ann or any of the hematologists, Dr. Brzezinski, to comment on why, but that keeping that hemoglobin up has less, not just pain crisis, but other complications. It does have side effects itself, right? So, but it has made a world of difference. And it really is the only other treatment we have out there besides chronic transfusions, which has its own.
So then what's with the, like, I think they're on vitamin D, right? And vitamin B.
They're almost all vitamin D deficient.
Well, that's black people in general. If you look at the statistics, almost all black people have vitamin D deficiency. Now, the question is whether black people natively have decrease and it's normal for them, but if you look at this, you know, what people consider normal, almost probably 80% of black people have vitamin D deficiency.
The penicillin is, as he already touched base with it, you know, their spleen doesn't work because it's getting doubled up with all these cells, so it doesn't tend to pull out the infectious cells either. One of the things our cells does. So they are considered functionally asplenic. Like they might have a spleen, but we consider it doesn't work. So the penicillin helps prevent infection.
And the vitamin D?
Vitamin B, not too many people are on it, but we are seeing some that don't methylate, which is a process in the cell of pulling out toxins. We're learning a lot about that, so it's very helpful. gives them energy, and essentially gives their cells energy, gives them energy.
Thank you. Good information.
Well, there's 10 minutes left, and I'm just gonna open up to any questions that everybody has, so we can just do it that way.
The short stature and the delayed sexual maturation, is that because of the sickle cell disease, or is that because of the medications that they're on for sickle cell disease?
Well, I think it was mainly due to the sickle cell disease. Anything that causes chronic hypoxia and chronic anemia, it's going to affect your growth.
Because there's a
So
lot of the
that's-
anemic disorders where they end up with shorter
Yeah,
stature.
yeah, and that's what I'm saying. So, you know, and when you look at most people are not, unless they're on hydroxyurea, and that's not all sickle cell patients, unless, you know, chronic penicillin has never been shown to have any complications like that. So, you know, most of the kids we see aren't on many drugs, you know, or unless they have specific complications like pulmonary hypertension or, you know, other things.
And then, when you were talking about bone marrow transplant as a cure earlier, is the reason why people don't get it because it has so many complications to go with it, or because African Americans are so difficult to match?
Well, that's definitely true. You know, we know that even with blood transfusions, that it's a better match if you can get other African Americans. You know, if you look at bone marrow transfer for cancer and stuff, like there's the Judy, it's a friend of mine's ex-wife that started the there's a bunch of African American bone marrow donorship programs because we need more African American donors because they're a better match for African American people. But, you know, I'm sure it's multifactorial. There's, you know, first of all, only certain people are considered, if you're a patient that has infrequent complications, wherever those complications is, then everything in medicine is benefit versus risk. Then the benefit versus the risk of a bone marrow transplant is not there. So, I mean, bone marrow transplants have come a long ways. You know, when I was a resident and they first started doing bone marrow transplant, you know, a lot of those people died. You know, that we don't see that as much anymore, but we do see bone marrow transplants that don't take. We do see people who have serious complications. It's still a serious thing. It's not something that, you know, the question is the cure worse than the disease? So for some people it is, and some people it isn't. And we don't have the facilities to do, I think we only can do 10 a year here or something, compared to the, you know, 100-something patients we have. So, you know, bone marrow, and it probably costs millions of dollars, you know, over the life of the bone marrow transplant. You know, society is not going to ever let bone marrow transplant be a primary treatment for sickle cell.
So my question was, there's not a set of symptoms that would indicate, let's start talking about transplant. Or is that true? I mean, like if you have a stroke and another stroke, does that kick on?
Yeah, I'm not qualified to, you know, you would have to talk to her or one of the hematologists. I can't tell you how they decide who qualifies for bone marrow transplant. I can tell you the people we've seen, the complications, and I can tell you that, you know, that some people it's just not worth it, but, you know, I'm sure they have set, just like that bone marrow transplant, criteria for every disease that bone marrow transplant is, you know, is possible. But I'm not qualified and I'm not going to tell you anything that's wrong because I don't know.
So it seems like the simple preventative measure we could do is just check a dose. Because I have it in my family, but nobody was ever tested to know that they have kids that have sickle cell anemia. In places like Africa, where they don't even have the resources that we have, usually if somebody's getting married, they'll ask each other what's their genotype, so they'll know. And if they have sickle cell trait, both parents today will not get married. So that's something simple that we can do, and it seems like we're not doing it. And that's why we still have these kids being born with sickle cell.
Well, but if you look at people who are really having kids, they should know. because they've been tested. You know, whether they know or not, somebody in their family, their parents knew. But I don't think that, I don't think that most people say, well, I'm in love with this person, I'm not gonna marry them, not having any children because we're both AS. I don't think society has moved that far yet. I just don't think it's happened, but it should be part of, and if you have a good doctor, it should be part of your prenatal lab. And they should ask the father of your baby to do the same thing.
But don't you think prenatals too late? Like my husband, he didn't find out till he got in the military. And that's really late.
Oh, I agree with you, but until you change the mindset, would you not have married your husband if you knew that, both of y'all were, carriers of the sickle cell gene?
Maybe I would have married him, but if both of us had the trait, I probably could reconsider having kids.
Well, but see, most people are not willing to make that, even though the risk is the same every kid you have. Most people are not willing to say, I'm not going to marry that person or I'm not going to have kids with that person. They'll take 25%, I'll take the chance.
Well, I've talked to several people that actively live in Africa and they travel here. They said there, like, it's a big deal. They'll ask.
And I'm glad to hear that, but that needs to happen here.
Because their kids die out there, they don't have the treatment, and like nobody wants to deal with the kid that's gonna die, and have to go do that.
I went to a medical convention in Cuba, and, it's one of the places where everybody gets health care. And, they actually, basic sickle cell stuff, they actually do great. Because everybody has a primary care doctor, everybody gets free health care.